Arya,
Yeah.
current, yeah, are you able to share?
Yeah, I think so. Are you able to see what's shared?
Yeah, able to see, but your footnote is also seen.
No, but okay, let's see. Let's do this then. Let's just close that. Okay,
I think,
what about?
yeah, looks good, looks good.
Yeah, I think just that when I share it, I'm not able to see any of you anymore, but that's okay.
Okay. So, Arya,
Yeah.
you're seeing Dr. Sijo Alex on the screen. He's our assistant professor of psychiatry. Probably you can just say hi. Both of you can say hi just to, get introduced.
Hi.
Hey, Dr. Arya.
Let me still figure out a way of being able to see you all. It's kind of odd to not.
We can see you.
Yeah, when I share the full screen, it's not letting me. Okay, now I can. Okay, now it should be okay, I think. Now I can see all of you and, okay.
All right,
Perfect.
all right. Looks good. Looks good.
Okay.
Yeah, this is Dr. Sijo. He's our assistant professor of psychiatry.
Nice to meet you.
Nice to meet you too, Arya. Actually, we are happy that you are with us on this eve of Mental Health Day. Thank you.
Yeah, thank you so much for the opportunity, though.
Yeah, so I think we'll start rolling. Yeah, can we start? Yeah, I think you guys can mute your mics so that I can. No. Good evening. Welcome to the international webinar at Believers Church Medical College and Hospital. Today is a very special day, eve of World Mental Health Day 2020. And as you all know, we are in the middle of a storm, a pandemic storm, and mental health is being terribly hit all over the world. And today we have with us child and adolescent psychiatry fellow from the Massachusetts General Hospital, Harvard Medical School, Boston, Dr. Arya Krishnan Rajalakshmi. After completing her undergraduation from PSG Institute of Medical Sciences and Research at Coimbatore, India, she went on to do her post-graduation in psychiatry at the reputable PGI Chandigarh. After a short stint as senior resident at the Institute of Human Behavior and Allied Sciences, New Delhi, she served as senior resident at the Department of Psychiatry at the prestigious AIIMS, New Delhi, where she did rigorous clinical work and teaching. In 2015, she joined as research scholar at the Department of Child and Adolescent Psychiatry at the Zucker Hillside Hospital, New York. After 3 years of rigorous training as resident in psychiatry at the Drexel University College of Medicine, Hahnemann University Hospital, Philadelphia, Pennsylvania, for the last 1 year, she has been the Child and Adolescent Psychiatric Fellow in the Massachusetts General Hospital. With a book chapter, 11 international publications, and numerous awards, including 3 Excellence Awards for Psychiatry Residency at the Drexel University College, winner of the CPT Award at Colloquium of Scholars, Philadelphia, Pennsylvania, winner of Mind Games on the Schuylkill in the Colloquium of Scholars, Philadelphia, and a number of other awards, and member of the Drexel Psychiatry Residency Program Evaluation Committee, and also a prestigious member of the Grand Rounds Committee at the Drexel Psychiatry Residency at Harvard. We have with us a doyen in the making. Welcome, Dr. Arya. A regular columnist at various regional health magazines an alumnus from Maastricht University, Netherlands. Our moderator for the day is the enthusiastic and brilliant consultant psychiatrist at BCMCH, Dr. Sijo Alex. Hailing from a great family of eminent psychiatrists, Sijo completed his undergraduation and PG in psychiatry from Tribhuvan and Pondicherry universities, respectively. Author of a postgraduate preparatory manual with keen interest in addiction and geriatric psychiatry, Sijo is an amazing professional. Dear Sijo, welcome to this international webinar, and over to you for the moderation. Dr. Sijo Alex.
Thank you for the wonderful introduction. So today is actually the World Mental Health Day Eve, and we have with us Dr. Arya Krishnan Rajalakshmi, who is a research fellow in child and adolescent psychiatry. And this year's theme of World Mental Health Day is Mental Health for All. And she has chosen a topic to talk on treatment of depression. So let me welcome Dr. Arya Rajalakshmi to start her session.
Hello, I hope everyone can hear me. The audio is okay so far? Is the audio okay? Okay, great. Thank you so much for the generous, rather elaborate introduction, Dr. Jacob, and thank you, Dr. Sijo, for having me here. Like I said, I think it's a joy to be here, and what makes it extra special is that I was invited for this talk by Dr. Jacob, who's a friend and classmate of mine from medical college days. And Jacob and I have shared the stage for many music performances in the course of our orchestra sessions. And those have been rather wonderful parts of my college life, but I don't think I'll do any more of that reminiscing at this time. It would suffice to say that I'm happy to be here. I hope to be able to make this a meaningful hour for you all. The topic for today's talk is the treatment of depression. And we can do rather an overview and an update for today. Now, depression and its treatment is at the heart of what psychiatrists do. And it makes up for a big part of clinical practice. What is worth noting is that no two people's depression ever looks identical. Their presentation has quite a bit to do with who these people are, their backgrounds, their values of the individual and the family, specific life circumstances, their specific personality makeup, attitudes towards illness, and so much more. Hence, treatment cannot be based just off an algorithm, and it has to do with better understanding of the individual and his or her journey. It's this emphasis on taking time, interest, effort at understanding the person with the illness, which makes psychiatry the meaningful venture that it is. With all of that being said, we're still at a point wherein continued research and a growing evidence base has contributed to building on our understanding of what the depressive illness looks like, what are some factors that contribute to its pathogenesis and have helped us devise treatment guidelines. I hope to spend the next hour or maybe a little lesser talking about what is known, where things are at, and some potential areas of interest with treatment. Okay. So the scope of today's seminar, we'll first introduce the topic, first make sure we all have a common understanding of what depression is as a clinical entity, quickly go over etiopathogenesis with special focus to neurobiological basis, go over some general principles guiding treatment, dwell a little more on medication-based strategies, quickly go over non-pharmacological strategies other than medication, and then conclude. Let's hope that I'm able to kind of stick to time and not ramble on too much. Okay, introduction. Major depressive disorder, as we all know, is a common mental illness. It's the reason why I also chose to talk on this topic. It's a condition that a significant proportion of the world population is affected by. The WHO global estimates indicate that 264 million people world over suffer of all ages. And not only does depression involve an experience of significant distress for the individual and the close family or caregivers, it's also associated with a notable decline in functioning at various levels, and it's known to be markedly impairing. It's a major contributor of the overall global burden of disease. One of the most pronounced concerns and the worst outcome of untreated depression is suicide. Mood disorders, and most particularly depressive disorders, kind of represent the single largest class of conditions that elevate the risk of suicide. The typical age of onset for depression was thought to be somewhere in the late 20s and 30s, but then it would suffice to say that there can be a wide spread when it comes to the age. People of all ages, like I said, can be affected. Depression prevalence, particularly in the younger age group, like adolescents, has been on the rise, and that's a concerning factor because by now we know that death by suicide represents the second most common cause of death in this age group of late adolescents and early youth. Women, we know, tend to be affected a little more than men, and despite the compelling nature of its presence, its impact, and what's at stake, it's sad to say that the reach of appropriate treatments for depression is appallingly low, even in this day and date. This is particularly the case in low and middle income countries. That has to do with a lack of resources, a deficit in trained healthcare providers, as well as the influence of stigma. While all of these factors are certainly quite pertinent, even in developed countries, such as even the United States, what we have learned is this very same gap, what the WHO calls the mental health gap between the need and the availability of treatment, and this divide is just so much more massive in the low and middle income countries, which is why it needs to be an increasing area of focus. Okay, moving over to our understanding of depression, I will first start by drawing your attention to the entity of depression. So what we loosely call depression in common parlance goes by this clinical entity called major depression or major depressive disorder. Now, this is a clinical syndrome which is just not the same as any experience of sadness. Sadness is an emotion we all know that's integral to the human experience. Sadness is expected and understandable in the face of disappointments and losses. It is a part of what makes us human. However, major depressive disorder is an illness, and it's a clinical disorder that's marked by the persistence and predominance of sadness, which tends to take over life and leads to interference in regular functioning. We have a certain set diagnostic criteria laid down by standard textbooks and guidelines, which kind of dictate the diagnosis. World over, it's the ICD, or International Classification of Disease, that lays out this definition, whereas in the United States, it's the DSM, or the Diagnostic Statistic Manual. DSM-5 is the most recent version. So let's familiarize ourselves with what the DSM says is required to make a diagnosis of depression in clinical terms. Now, the DSM says that 5 or more of the following 9 symptoms have to be present together for at least 2 consecutive weeks. And of these 5 symptoms, it says 1 symptom must be either depressed mood or a loss of interest or pleasure. What are these 9 symptoms? Let's take a look at that. We start off with depressed mood because, after all, this is a mood disorder. In children, this can look somewhat different. It can even look like irritability. It doesn't just have to look like sadness. There is the second criteria is a loss of interest or pleasure in most activities, which is what's called anhedonia. This is also a central criteria of depression. The other criteria have to do with changes in sleep, which can be either an excess or a deficit, changes in appetite with concomitant changes in weight. There is this mention of psychomotor retardation. What that means is just a slowing, just mental slowing, which can present as slowing of thought, slowing of speech, or generally slowed activity. Or it can be the opposite of agitation, which is a state of restlessness, not being able to sit still, kind of racing thoughts, that kind of thing. What's also at the core of the depressive syndrome is a state of low energy, inexplicable fatigue or tiredness. There is the decreased ability to concentrate, think, or make even small decisions, which is a very frequent accompaniment of depression. This is responsible for academic struggles and setbacks in children and can lead to difficulties in the work setting for adults. If you ask a cognitive theorist, they would say that these self-devaluing cognitions or thoughts of worthlessness, excessive or inappropriate guilt, helplessness, or hopelessness are also quite at the heart of the depressive syndrome, which is why that's a definite part of the diagnostic criteria. And then there are recurrent thoughts of death or suicide or even attempting suicide, which kind of comes to the extreme and is a marker of severity of the depressive presentation. Now, what we can see here is you just don't have sadness, which is required to make a diagnosis of depression. You need all of these other symptoms. At least 5 of them should occur together. And I think the operative part is that they need to happen, they need to occur for most of the day, nearly every day, for at least 2 weeks. So I know all of us have rough days. We have an hour or two or a part of the day wherein we feel kind of low and glum. That wouldn't suffice. Only if it takes over your life for a significant chunk of time does it merit a diagnosis or consideration for the diagnosis of depression. I'll also like to point out that what's being referred to as major depression here actually refers to unipolar depression, which is when depression occurs in the absence of hypomanic or manic episodes. So hypomanic or manic episodes are states of elevated mood or excessive energy, which is quite the opposite. So when depression occurs along with or in the background of hypomanic episodes, then that would represent bipolar depression, which is a totally different entity. It's not the same as just major depression. It has different treatments. That's not what we're going to be going into today. What I also didn't go over in the available diagnostic criteria is that when you have all of these symptoms, they must be to the degree that it causes either significant personal distress or psychosocial impairment. And it also requires that it should not be the direct result of a substance or a general medical condition. Bereavement or a loss does not exclude the diagnosis of a major depressive episode, meaning somebody can suffer from a loss of a near or dear one, and they can still have major depression. It doesn't kind of exclude that possibility. Okay, moving on to kind of the understanding of depression. While I recognize that the focus of today's talk is the treatment of depression, it will only be fair to just spend some time and quickly going over the current understanding of what is responsible for depressive states. We would start off by saying depression is not the product of a single etiological source. We do not know of its cause with the directness and linearity as, for example, we know of the cause of typhoid, right? Our understanding of depression is guided by a certain framework, which you can see here, called the biopsychosocial framework. What this means is we believe that depression results from a complex interaction between certain social determinants or social precipitants, which could, for example, look like poverty or migration or a specific life event like a loss. And so when these social factors intersect with a certain personality makeup or a configuration, for example, an individual could have attributes of low self-esteem, a tendency towards unhelpful beliefs or perceiving the world, weak or poor early attachments, then these could be certain psychological vulnerabilities. And when they meet biological predisposing factors in the form of family history or certain medical conditions, then all of this sets the stage or makes them so much more prone to develop a depressive illness. So this is kind of where our current understanding stands. And this is not a scientifically validated tenet. It's of course not perfect, and still it happens to be a utilitarian approach to understanding why this particular individual at this time is affected and helps tailor treatment accordingly. I decided that for today's seminar, we could go over an outline of just the biological factors that are theorized to play a role in the genesis of depression, because it would be beyond the scope of this seminar to go into details about some of these other dimensions. So biological factors, we can go over aspects like genetics, what are some neural structures involved, neurotransmitters, I'll spend a bit more time on, neuroendocrinological pathways, neuroimmunological theories, and intracellular signaling we could quickly kind of skim through. Okay. So genetics, let's see, what do we know about the genetics of major depression? By now, we know that depressive illnesses are much more likely when there's a family history of the same. Family studies have shown that there is a 2 to 4 times greater risk in first-degree relatives. Twin studies have revealed that there's a dizygotic twin concordance of 14 to 43%. There's a monozygotic twin concordance of 23 to 67%. The heritability of depression, which is known, falls between 40 to 70%. Now we know that heritability refers to the extent to which genes are known to affect the vulnerability and occurrence of a disorder, or kind of very simply put, how genetic is an illness is kind of what this determines. And so a figure of 40 to 70% would mean that genes do play a significant part in the occurrence of this condition. Now, the search for genes always tends to start with a mission to trace a single gene that could be responsible for a depressive predisposition. We have come to repeatedly identify certain functional polymorphisms of certain genetic loci, like say the serotonin transporter region, the BDNF-related genetic loci, the COMT gene, FKBP3. These are certain polymorphisms that have repeatedly come up, and there was some excitement around this, but this excitement ended up being short-lived. By now, we've come to understand that MDD is not a single gene disorder. There are likely multiple genetic foci of small effect that come together to kind of influence the predisposition of depression. Okay, the neuroanatomy of depression. Just like genes, similarly, there was an interest in being able to identify a single area or anatomical region that could be the seat or source of depression. Neuroimaging research over the last decades have helped us build on our understanding of the anatomical sites that are relevant in depressive illness. So some of the areas that have repeatedly come up are some cortical regions as well as subcortical regions that have to do with emotional regulation and salience of stimuli. Like say we see here that the ventromedial dorsolateral prefrontal cortex, the anterior cingulate insula, along with the hippocampus and some the limbic region, which includes amygdala and then hypothalamus, the reward center or nucleus accumbens, some basal ganglia structures. They all have been implicated. Now, we don't think of it as these independent regions being responsible, but we tend to understand this as certain anatomical pathways or functional neurocircuitry being dysregulated. And this has also been replicated in neuroimaging studies. And yet we don't kind of have a specific answer, but we do have some more information. And it's based on this knowledge that we've been able to capitalize on this to develop somatic treatments like DBS or TMS for the treatment of depression. So this is relevant to know. Neurotransmitter system. So an aspect that has gained the most popularity in what is believed to drive depressive illnesses has to do with abnormalities in the neurotransmitter system. Most focus was received by what's called the monoamine neurotransmitter system. We all know that neurotransmitters can be broadly classified into biogenic amines, amino acids. Amongst the biogenic amines, we have catecholamines, we have serotonin, dopamine, histamine, all of that. The triaminergic system, trimonoaminergic system, which is a serotonin, norepinephrine, dopamine combination, has probably received the most attention. And rather recently, interest is extended to some other systems like the glutamatergic system. But before we go on to these newer developments, I think it's pertinent to spend some time in talking about why there was this interest in the monoaminergic system, which has to do with, there was even this theory. So why I say that it's important to discuss this is because the monoaminergic system was thought to be so crucial to the occurrence of depressive illnesses that it gave rise to this theory called the monoaminergic deficit model of depression. This held sway for quite a while and remains a common influence in guiding medication management. So what does this theory refer to? So as we see here, we have like three neurotransmitter systems that are mainly looked at. Like I said, it's a serotonin, norepinephrine, dopamine. Per this theory, there's this belief that a neural synapse needs to have a certain amount of neurotransmitter for normal kind of mental functioning. And this theory of depression postulated that when there is a deficit or scarcity of monoamines in the synapse, then that makes an individual so much more vulnerable to depression. And hence it follows that the treatment target would involve kind of correcting this synaptic deficit and increasing the amount of monoamine in the synapse. So while this looks pretty straightforward and cool, we know by now that this is kind of too simplistic. This theory doesn't do enough to explain our understanding of this complex entity called depression. Because if it were to be true, then we would be able to, through quantitative analysis of monoamine levels in afflicted individuals, we should be able to derive that all individuals with depression should have low levels of serotonin, norepinephrine, dopamine, but that isn't the case. And so there were definite loopholes to this theory, and then we have moved on from this. We've moved on to this for a brief period, actually. There was this revision of this theory to what's called the monoamine neurotransmitter receptor model of depression, which is just a slight extension of this theory. The reason that this kind of revision was made was just based on what we know about antidepressant actions. Now we know that some of these common antidepressants, like say SSRIs, which are the serotonin reuptake inhibitors, or SNRIs, which are serotonin norepinephrine reuptake inhibitors, they have an immediate action in terms of increasing the synaptic levels of neurotransmitters. However, their effect in affected individuals only is delayed. It does not start before a few weeks of starting the medication. So this time lag between the immediate repletion of synaptic neurotransmitters and the time that it takes for the medication to act gave rise to this adapted theory called neurotransmitter receptor model, which said it's probably just not the increase in synaptic neurotransmitters, but it's this downstream adaptive corrective downregulation of neurotransmitter receptors that's probably responsible for antidepressant action. And it also tended to explain the timing of antidepressants. And so for a brief while, it was felt that now we have the answer to how antidepressants work. However, this theory again lost steam because not all individuals, not the imaging of all individuals showed that there was such a down regulation. And so by now we know that both these theories are kind of outmoded. They don't do enough to explain the complex illness that depression is. And so it was believed that maybe it's not both of these processes. Maybe there are downstream processes beyond the synapse, beyond the receptor that's responsible for some of the changes in depression, which gave rise to some look at intracellular signaling cascades. And they have to do with how, like I said, it's just not an increase in the synaptic concentration or receptors, but there are processes that happen within the neuronal cell that have to do with signal transduction and gene expression that were thought to be dysregulated. One particular target or candidate mechanism that was seen was the deficit in gene expression for BDNF, which stands for brain-derived neurotrophic factor. It's important in sustaining the viability of neurons. It was postulated that under stress, the gene for BDNF may be repressed, hence leading to atrophy of vulnerable hippocampal neurons, increasing the predisposition for disorders like major depression. There were some findings that lend support to this theory, but again, this is far from an all-explanatory theory. We've also, interest has also been shifted or has also moved to some other pathways and how they may be involved. One of it is the neuroendocrinological pathway. Even if these were never thought to be standalone causal mechanisms, they were thought to be associated events that had a role to play. Now we have three such systems listed here. HPA, as we know, is the hypothalamo-pituitary adrenal axis or the stress response system. This was thought to be hyperactive in major depression. And one of the ways that they established this was in normal individuals, if you would administer dexamethasone, then there'd be an adaptive suppression of CRF and cortisol release, but there was a failure of this response to be observed in depressed individuals, which lent support to this theory. But by now we know that this is not pathognomic of depression, and yet this has been a mechanism of interest in drug development. Another pathway is the HPT, or hypothalamo-pituitary thyroid axis. Interest came about because 1/4 of patients with MDD have thyroid dysfunction. Frequently, this happens to be subclinical hypothyroidism. These patients also tend to have poorer responses to antidepressants. This guided the use of thyroid supplements as an augmentation in treatment and has been seen to be useful. The last, as we see, is the HPG, which is the hypothalamo-pituitary gonadal axis. Why did we start looking this way? That's because we know that depression is more preponderant in women. There has been interest in premenstrual dysphoric disorder, postpartum depression, which kind of led us along to look at hormones and their possible role. It has been seen rather recently that we might have been onto something, because this guided the development of a very recent drug in the treatment of postpartum depression, but I'll talk about it when we get to that point. One of the last kind of areas, is a rather recent area of interest in understanding the neurobiology of depression, is the neuroimmunological pathways. It's been seen that depression has had an association with chronic inflammatory and immune-mediated conditions like lupus. MDD has been seen to be associated with an increase in acute phase reactants. There's been an increase in pro-inflammatory cytokines, and there's been a peripheral immune activation that's been observed. There's been increasing focus on an imbalance between pro and anti-inflammatory cytokines in illnesses like depression. Hence, this is proven to be an area of research for developing therapeutic targets. Okay, to summarize, because we do want to move on to treatments, which is the focus, by just going over all of this, we know that biological processes interact in genetically at-risk individuals to culminate in depression. Clarity is lacking on their relative importance. It's unclear if these are actually causal mechanisms or just accompaniments or consequences of the depressive state. Yet there exists a strong biological basis and explanation to depressive disorders, is what I want to underscore. To medical students, I think it's important to register that depressive disorders very much have biological underpinnings. These are disorders of the brain. These aren't just figments of one's imagination. They're not just a reflection of characterological weaknesses or laziness, and they cannot just be willed away. You can't just ask someone to snap out of it. They call for, support is an important part of treatment for depression, and yet it calls for a referral to a professional for formal assessment and treatment, which is a nice segue into the main focus of the seminar, which is the treatment of depression. Okay. All treatment would start with assessment. Assessment would certainly have to do with establishing diagnosis, clarifying comorbid illnesses, which could be both psychiatric as well as medical comorbidities. Establishing the appropriate setting of treatment would be one of the first things that we do after establishing the diagnosis, right? Because, and this is a decision that's made or guided by certain parameters. What's the extent of suicidal risk? What is the capacity of patients to actually adhere to recommendations that are made? What is the level of support that they have? What are the kind of psychosocial stressors that they are facing? all of these would be factors that would help guide the choice of the appropriate setting for treatment, right? For example, inpatient treatment may be indicated in an individual who presents with high suicidal risk, or in a patient who's so hopeless, minimally motivated, and so impaired that it makes it unlikely that they'll be able to adhere to the recommendations that are actually made, or in individuals who really lack support from their family or significant others. And if the home environment or the environment where they live in itself is a big source of stress, then that might also make outpatient less ideal, and we might need to look for kind of inpatient and other settings of treatment. So the treatment of depression, we can quickly go over this because that's not really relevant in the overall scheme of things right now, but the treatment of depression is kind of stacked into 3 layers, which is more of a time frame based kind of layering. The treatment of depression is organized into acute, continuation, and maintenance phases, which just has to do with the timeline. Like the first 3 months of treatment would be the acute phase. And the next kind of between 4 to 9 months is the continuation phase. All patients would have both of these phases of treatment, whereas the maintenance phase is kind of less definite as to what's the duration of this. Most people say at least 2 years of maintenance treatment would be required, but not all patients would need maintenance treatment. Like say if an individual has had 2 or at least 3 episodes, then of course they would be candidate for maintenance treatment. If they've had incomplete recovery between episodes, then that would also make them candidate. There are a list of other factors which we don't have to go into right now. But the focus of acute treatment, as we see here, is full remission, and it's not just the response. So in the treatment of depression, response means a 50%, at least a 50% reduction in symptoms. Remission means when the symptoms have abated to the extent that they no longer meet syndromal criteria. So that's kind of the goal, as well as the restoration of function. In the continuation phase, we aim to sustain gains that have already been made and to prevent the recurrence of the index episode. Maintenance phase aims to prevent a new episode all afresh. Okay, so what are the treatments available? They're broadly grouped into pharmacological, medication-based treatment and non-pharmacological treatment, as you can see here. The non-pharmacological treatments would include an array of approaches, starting from psychotherapy to somatic treatments like ECT, TMS, VNS. There is some peripheral role to light therapy too, we can quickly go over. But what here guides the choice? Like, how do you know which of these approaches do you start with, for whom? What is the sequence of treatments? Is a combination of them called for? All of these treatment considerations, there is no cut and dry answer for this. Treatments are not a matter of one size fits all. The choice of treatment, as I said, is guided by certain parameters that I've listed here on the right. The first of them would be the severity of illness and extent of functional impairment. The acuity or extent of suicidal risk is a significant other parameter. What the patient prefers to do would definitely be relevant. The nature of depression, like is there a specific form of depression, like seasonal affective disorder would be another such factor. Past history of response would definitely guide our current choice of treatment. We would want to look at, is this person someone who's already tried and failed a list of other treatments, which would make them treatment refractory. So then we would adopt a different path of treatment. And of course, the availability of resources would be particularly relevant for someone who, say, wants psychotherapy or TMS. These resources would have to be available to choose them, right? So these are some factors that would influence our choices. For example, if this is a patient with a mild form of depression, without too much impairment, with a lot of support, who is willing to go into therapy, then that would be a fine first choice. We wouldn't have to introduce medication straight away. However, if this is a person with moderate to severe illness who isn't really able to function at work or school or college, they are also expressing suicidal thoughts, then that would be a setting wherein you would want to consider medication treatment or maybe even other somatic treatments. Okay, let's first start with medication. We don't have to spend time here because there are many ways that medication or antidepressants have been classified, and there is no unified kind of top system of classification. One quick system is just boxing them into earlier first generation antidepressants or later newer second generation antidepressants. Earlier ones are the MAO inhibitors, TCAs. The newer ones include a list of SSRIs, SNRIs, atypical agents, and serotonin modulators. The next slide looks somewhat intimidating and cluttered, I recognize, but the reason that I still have this slide here is because we have moved away from kind of like chemical structure-based descriptions of antidepressants. Our current classification has more to do with functional kind of criteria, meaning how antidepressants work, have helped categorize them into different classes, right? So this slide is just a list of kind of different mechanisms that some of these medications used to treat depression work. And I know this slide just looks like kind of a mix and match of various letters and acronyms like SNRIs, NRIs, NDRIs, and can look rather puzzling. I don't expect anyone to kind of completely remember or register all of these names, but I do want to go over some of them group by group. I did think that before we start looking at individual meds, it might be useful to have kind of an overview in how these meds act. What I mean is, there is something distinctive to how each of these individual meds work, and still there are a lot of commonalities that's at the basis of how antidepressants work. And so I wanted to have a slide wherein we'd be able to look at what are some basic mechanisms that underlie antidepressant action. Taking a closer look at this slide, this is a picture of a synapse, right? A neural synapse. So this side is the presynaptic terminal, and this is the postsynaptic terminal. The rift between is the synapse. And so the neurotransmitters that are usually synthesized in the presynaptic end are packaged into vesicles. They're released into the synaptic terminal. Their action depends on their binding onto receptors, both at the presynaptic end, you see the receptor here, and at the postsynaptic end, there are receptors, right? So that's what forms the basis of neural activity and neural signaling. So you would recall our discussion on the monoamine hypothesis of depression a while ago, which said, what's basic to mental health and normal mood is having a normal level of synapse of neurotransmitter in the synaptic cleft. So this is kind of fundamental to it. However, in all individuals, there is a certain regulatory system that is at play that works to kind of metabolize these neurotransmitters, kind of break it down so that there isn't as much available. What are these two main mechanisms? One, some of the neurotransmitter in the synapse is either broken down by a degrading enzyme, which is the monoamine oxidase enzyme, or they could be taken up into the presynaptic terminal again through a process of reuptake using transmitters. So both these processes serve to kind of cut back on the amount of neurotransmitter that's available in the synapse. So both of these mechanisms were then capitalized on to develop medication that can help increase the neurotransmitter in the synapse. One, if we were to develop drugs that would block MAO, monoamine oxidase, then we would block degradation and have an increasing amount of neurotransmitter. So that's one mechanism. The other very popular mechanism is reuptake inhibition, wherein if we were able to develop medications that can block these transmitters here, then you would stop the neurotransmitter from kind of leaving the synaptic terminal. So you would increase the synaptic neurotransmitter, and this is a very common central mechanism. These were some of the earlier mechanisms. So in the recent times, our interest is extended beyond this to other kind of ways of drugs have targeted both presynaptic and postsynaptic receptors, also as systems that can be targeted to develop drugs for action. So we can look at some of them up close. Okay. Let's first start with these classic antidepressants, which are the MAOIs and the TCAs. We don't have to spend too much time. We can quickly go over how they act, though. The figure on the left outlines the mechanism of action of MAO inhibitors. As we already said, MAO stands for monoamine oxidase. This is an enzyme that degrades the monoamine neurotransmitters that are released here. There are two subtypes, MAO-A, MAO-B, which kind of acts rather differently, subtle differences though. And so it was postulated that if we could get drugs to block this MAO-A enzyme, then we could block the degradation, right? Which sounds fair. The figure on the right is the mechanism of action of TCAs. So the TCAs, as you can see, work on reuptake inhibition. We said that's the other system through which synaptic neurotransmitters are eliminated. So if we could block the reuptake of serotonin and norepinephrine, then we could increase their levels in the synapse. So that's how TCAs or tricyclics worked. So what is wrong with them then? They seem to be working by reasonable principles. There is nothing wrong with them actually. Efficacy-wise, they seem to be just as effective as a lot of other antidepressants. But the problem has to do with their side effect profile. As you can see here, the TCA just does not involve the serotonin and norepinephrine receptor. Its actions span across a lot of other unwanted receptors like the muscarinic receptors, alpha adrenergic receptors, and histaminic receptors, and the sodium channel, some blockade, which is responsible for a lot of unwanted side effects, which makes them rather unpopular and even dangerous when taken in overdose. Let's look at what the concern is with the MAOI inhibitor is this particular phenomena called the tyramine reaction, right? Simply put, tyramine is a precursor of norepinephrine. There are some foods that are rich in tyramine, which would increase norepinephrine, which could run the risk of causing a hypertensive crisis, an elevation in blood pressure. But normally individuals are protected from this because monoamine oxidase can break down the norepinephrine and protect our body from risky elevations in blood pressure. However, in individuals who are taking these drugs, MAO inhibitors, this normal protective kind of system of MAO is blocked, and hence these individuals are so much more vulnerable to dangerous elevations in blood pressure when they take a list of kind of foods that are rich in tyramine. So this calls for a lot of caution, making it rather unpopular. Both of these drugs continue to be used, but they're reserved for use in treatment-resistant conditions. Moving on to kind of what we now regard as the mainstay of treatment, of medication treatment for depression, are SSRIs, right? So SSRI stands for selective serotonin reuptake inhibitors. These are probably the first line of treatment when it comes to medication treatment of depression in the current day and age. They're most widely used because of their superior tolerability profile. They have fewer interactions. Their efficacy is established. What makes them so popular and kind of better tolerated is because their action is reserved to a specific kind of neurotransmitter receptor, which is the selective, or the neurotransmitter system, which is the serotonin system, as opposed to the TCAs, which we said have a bunch of other unwanted receptor actions. So these are cleaner meds. They're overall better tolerated, and yet they could have some minor beginning problems like GI problems, headache, dizziness, sleep appetite changes. Sexual side effects are actually concerning with SSRIs. They can occur as commonly as in 30% of individuals who take them, making them kind of less favorable in these individuals. Some uncommon problems with SSRIs that we see more in older individuals could be the risk of bleeding, hyponatremia. There is what's called serotonin syndrome, which is a state of serotonin excess. This can happen when you combine a bunch of serotoninergic drugs. This can be quite an emergency, but we don't have to go into this right now. Some controversial problems with the use of SSRIs, particularly in younger individuals, are this debate around, do they actually cause an increase in suicidal thoughts or not? There is so much controversy around this, and it's unfortunate that it comes with a black box warning, but by now that we know that benefits far exceed any risks. And so it's worth discussing this with the patient. Activation is a state of restlessness, impulsivity, which is particularly relevant in younger children, and that's an uncommon kind of side effect with SSRIs. So if these were such great meds, why are we still looking for newer treatments? That's because even though we have all of these meds already, the effectiveness of available antidepressants is less than ideal. They have a slow onset of action. It takes weeks for the action to actually start. And they do have an unfavorable side effect profile, which is the reason that we continue to be on active search for new drug development. Okay, so moving on to that, what are some of these kind of relatively newer drugs? So the first class of meds that were developed were this extension of SSRIs, meaning they're also reuptake inhibitors, but they focus on other neurotransmitter systems other than just serotonin. Like SNRIs are serotonin and norepinephrine reuptake inhibitors. NDRIs are norepinephrine and dopamine reuptake inhibitors. NRIs are just norepinephrine reuptake inhibitors. So although these are still kind of used commonly in the clinical setting, none of them have proven to be superior to SSRIs. And so while they're used commonly, they're still kind of second-line drugs, and SSRIs remain the mainstay. So after the next class that followed these reuptake inhibitors are this class called the serotonin modulators. What they do is they go beyond just reuptake inhibition, which was the main mechanism of action of the meds that we discussed so far. Their actions extended to pre and postsynaptic receptors, which we would recall from the figure that I discussed earlier. So what are the serotonin modulators? There are two main classes. One are the SARIs, which actually stands for serotonin antagonist and reuptake inhibitor. While trazodone and nefazodone were older drugs in this class, it was established that trazodone really didn't have too much of antidepressant action. So a newer medicine that was developed that acted in similar ways as vortioxetine, that goes by the name of Trintellix. As you can see, it has an array of receptor actions, like it is an antagonist in certain serotonin receptors, it's an agonist in 5-HT1A, and it's a partial agonist in 1B, right? So its actions are rather diverse. So there was a hope that this might just prove to be so much more effective. It was FDA approved for the treatment of depression earlier this decade in 2013. However, it is only reserved for use in those not responsive to standard meds usually as an option. Side effect profile is fairly similar to SSRIs, although nausea can tend to be a big deal in certain patients. Like I just had a patient, an adolescent, who couldn't tolerate this medication because of nausea, and so he had to discontinue this medicine. Vilazodone, as we can see on the right, falls under this classification of SPARI, S-P-A-R-I, which is actually a serotonin partial agonist and then a reuptake inhibitor. FDA approved it for the treatment of depression in 2011. Expectations, it came with high expectations that it would do so much better, it would have a faster action, it would be more tolerable, it would be so much more effective. It hasn't quite demonstrated this kind of superiority, disappointingly so. Just like vortioxetine, it's reserved for use in those who don't respond to traditional meds. And it's just kind of a Me Too drug. So both of these meds overall have not yielded in a big way, even though they came with some excitement. There is this added constraint of costs and insurance approval in this country. And so we only try to use them when some other meds fail. The last two meds in the class of medication, which are exciting developments for the field of psychiatry very recently, are one, this class of glutamatergic agents, or Spravato, which is ketamine, which is a ketamine-based compound, and the other I'll talk about soon. S-ketamine is something that was very recently approved. FDA approved it in 2019 for depression that was resistant to antidepressant treatment. Let's first talk about how did we even get here, right? So far, as you would all recall, all of this discussion talked about repeatedly about serotonin, norepinephrine, maybe to a certain extent dopamine. So these were the neurotransmitters that had been looked at closely all along, right? So however, they weren't doing so well. The treatment of depression wasn't at a great place. And so interest extended to certain other systems, one of which was the glutamatergic system. we know ketamine had already been in use for quite a while as an anesthetic agent. And so they started looking at it for the treatment of depression. And there was a lot of FDA push for approval because of its rapid effects in amelioration of suicidality and relief in depressive symptoms. In the form that it was initially introduced, it was given as an infusion, IV infusion. So that was a limiting factor because it could only be administered in certain certified settings, which was why the FDA approved a revised form of S-ketamine, which is an enantiomer. It's a potent enantiomer, which is available under the brand name of Spravato in the US. It's a nasal spray, making it somewhat more amenable to use even in outpatient settings. However, it's a fairly recent medication. We still don't know entirely about its safety profile, about whether its benefits would be lasting. Some of the concerns that come up are dissociative symptoms, sedation, cognitive disturbance right after administration, concerns with elevated blood pressure, and the abuse potential is what makes it only available for administration in a supervised setting. The other interesting development is that of this medication called brexanolone, which actually works, which was also FDA approved last year, 2019, early 2019. So 2019 seemed to be an exciting year for depression treatments because usually years roll by before meds can be approved. And here in 1 year, we saw 2 meds that were approved. So this wasn't a medication that was approved for MDD at large, but strictly for postpartum depression. And yet I thought it's useful to talk about. This is a medicine, brexanolone is a preparation of allopregnanolone, which is actually a metabolite of progesterone. And so and this was also thought to have effects on GABA signaling. So we see that here we have a connection between hormone-based systems and neurotransmitter systems. And so this was a very interesting and novel mechanism of action. This, as I said, was approved last year. Similar to ketamine, this is only administered in a certified center. It has an interesting, it's only administered as an IV infusion over 60 hours. Close monitoring is required, but it seemed to be quite effective and the effects are quite quick. We don't know if the effects would be lasting as yet. No major side effects have been spotted either. So it remains to be seen as to how well both of these new meds will fare in the coming years. Some other meds that are just happen to be areas of interest, but none have been approved as yet, are other hormone-based treatments. We have anti-inflammatory therapies, like even NSAIDs that have been seen to be promising areas in the treatment of depression as augmenting agents, nutrition-based kind of elements like omega fatty acids, methionine E, and tetrahydrobiopterin. All of these have had favorable results in the initial treatment of depression. But I won't go into all of that now, but they are potential areas of interest. So how do you, from all of this that's available, how do you know which one to choose for which patient? This, again, there isn't any kind of algorithm to guide it. The choice is guided by factors like prior history, side effects, drug interactions, ease of dose adjustment, availability, costs, and the likelihood of discontinuation symptoms. I know we don't have time to talk about this, but discontinuation is something that can happen when SSRIs are abruptly stopped. This isn't life-threatening, but just a bunch of nuisance symptoms that can be avoided by a gradual taper. So there was some interest in pharmacogenomic testing that was developed to see if that could inform individual medication choices. However, we are still not at that point as yet. What pharmacogenomic testing can tell us would be if there are individual genetic differences in their cytochrome metabolic pathways, making them less or more prone to side effects, then that is some information we can gauge. But we wouldn't really be able to tell what medication would be a best fit for what individual just based on this testing. I know we're out of time, but let's skim through some other methods of treatment. Psychotherapy, we said, is a solid other arm of depression treatment. It's a crucial element. Approaches to therapy can be very varied. There are so many formats of psychotherapy available, but 2 particular forms of therapy that have been approved in the US for treatment of major depression are cognitive behavior therapy, CBT, which is based on the tenet that thoughts actually influence mood, which influence actions. And so being able to identify and correct challenging thought processes could yield results is what CBT is based on. Interpersonal therapy is based on kind of fundamental deficits in interpersonal connections and working on that. Both of these are short-term psychotherapies. They aren't indefinite long-term methods, making them favorable. They can be the sole treatment for milder forms of depression, but if they're more severe, then usually a combination with medications is recommended. The use of therapy depends a lot on the availability of skilled therapists as well as patients' time and willingness. The last segment is somatic treatments. Somatic treatments are non-medication methods of treatment that are based on neuromodulation. And the methods that have been approved for the treatment of depression are ECT, TMS, and VNS. So DBS, which is deep brain stimulation, has been talked of for other psychiatric disorders, but it hasn't as yet been approved for the treatment of depression, which is why I haven't included it here. ECT has been around for quite a while now. It was introduced in 1938, but it received a lot of negative rap thanks to unhelpful media portrayals. But then you can't really just blame media, because it's true that initially ECT was administered without anesthesia. So that's quite an unsettling kind of prospect. Thankfully, we've come far away from this stage. What we use now is modified ECT or electroconvulsive therapy, which involves brief electric stimulation of the brain under anesthesia. So you first administer anesthetics and then muscle relaxants to make sure that you don't have visible kind of motoric convulsions. This is a very effective form of treatment. Up to 80% of people respond to this form of treatment. However, it has certain limitations, right? It depends on the availability of a special care team, including anesthetists. It comes with certain problems, of which memory impairment is the most concerning side effect. And hence, it's only reserved for certain conditions like severe depression, suicidality, psychotic symptoms, or it could be used in pregnancy. It's fairly safe for the treatment of depression in pregnancy. TMS is one of the newer somatic treatments. It stands for transcranial magnetic stimulation. It involves an electromagnetic coil that's applied to the scalp to generate brief magnetic pulses for cortical stimulation. So it targets a specific area, DLPFC, which is the dorsolateral prefrontal cortex. One of the advantages of the TMS over some of the other kind of methods are it's non-invasive. Unlike DBS or VNS, there's no need for surgery. Unlike ECT, there's no need for anesthesia. It's indicated for treatment-resistant depression because the remission rates aren't kind of anything to gloat over. They're only 30 to 35%. However, it doesn't come with serious side effects. Seizures are very uncommon. The last somatic treatment would be VNS or vagal nerve stimulation. FDA has approved it only for resistant depression when an individual has failed 4 antidepressant trials, ECT or both. That's when this is considered. It's not to have mixed benefits so far, nothing spectacular. Effects are seen to be gradual. There are some, of course, surgery-related concerns, side effects that could happen, changes in voice, hoarseness, swallowing difficulties could be concerns. This isn't a very popular method of treatment is what I'd like you to remember. Light therapy is kind of a peripheral method of treatment that can be used, reserved for use, like say in seasonal affective disorders, depression that only happens in certain kind of times of the year. And it's also used to augment the effects of other forms of treatment. It's safe to use in pregnancy. There are certain parameters that guide the use of light-based treatment. The side effects are mild. Before we wrap up, the course of depression we know isn't a very mild one. Recurrence usually happens to be the norm. If individuals have one episode, the risk of another episode is 50%. And this risk really goes up if there are 3 episodes, and the risk of having another one is over 90%, right? And then the response to available antidepressants is sobering. Only 2/3 respond, and only 1/3, up to 35%, remit with the first antidepressant trial. So there is a lot of kind of potential to develop effective treatments. There are a lot of reasons for non-response, wrong diagnosis, poor adherence to treatment, inadequate treatment, other psychological factors, and so forth. But treatment resistance would be a whole seminar in itself. We don't have to go down that path. To summarize, I think it would be important to remember from this seminar that depression is a common impairing condition that's responsible for substantial personal distress, family burden, disability, and healthcare costs. Depression is best understood from the biopsychosocial framework. There are multiple treatment options that are available, and yet none that have stellar effects. Expanding our understanding of the illness, its causation, and treatment remains an area of rich study. The hope is to develop better biological-based diagnostic markers or neural signatures, and to develop individually targeted treatments that could really guide the management of depression. That's all that I have for today. I did a lot of talking. Thank you for your attention and for your participation.
Thank you. Thank you, Dr. Arya Krishnan Rajalakshmi. It was a very extensive and all-inclusive session, right from the etiology, etiopathogenesis, clinical features. I think you covered almost every important aspect of depression. It was nice. From the audience, do we have any specific questions or queries? Yes, I think we have a question from Evelyn George. At what age can a child be started on antidepressants?
Yeah, so it's a pertinent question for me because I'm currently kind of in the world of child and adolescent psychiatry. And so you'd be surprised as to how early antidepressants can be started. They're actually indicated and are known to be quite effective and tolerable. Like the FDA approves 2 antidepressants, actually, the fluoxetine and escitalopram for the treatment of depression even in kids under 12. And so, of course, there is you go by this parameter of if a child is, say, 6 or younger, what we call preschool children, then we try our best to avoid medication-based treatments. But in our clinic, we've had kids as young as 6 and 7 who've needed antidepressants, who've benefited a lot from it too.
And I think the particular concern raised was probably like, as you mentioned in your talk, there were lots of news that SSRIs could potentially lead to suicidal intent among young people. I assume that's one reason this specific question was raised by Evelyn George. Thank you for your...
Yeah, it's a good question and it's relevant. It's a question that a lot of parents, of course, have a lot of reservations around because the idea of starting their young child on an antidepressant is something that takes a lot of thought and worry for parents. And this black box warning that comes with this medicine of suicidality makes it very inconvenient and it makes for a very long discussion with parents. But then it's so controversial. Over the last decades, we've amassed information that says that, you know, kids who do get this who are on antidepressants don't really end up with suicide, with death from suicide because they're on the, it's very hard to establish, but it would suffice to say that the benefit from antidepressants far exceeds the risk that it comes with.
Exactly, it's everything is between the risk and benefit ratio. So since we have enough clinical evidence to assume that the benefits will outnumber any potential risk, so I also completely agree with you. Do we have any other? Yes, I think from Dr. Jacob Jasuran, many practitioners still go for TCAs.
Yeah, and so I did my training and 3 years of work in India. And so we used to use TCAs a lot, not as much even there for depression, but I know we were using it for other things like pain and migraine and things like that. I think in India, it's also a question of what's available, and some TCAs and a lot of hospital formularies are free. And so the cost considerations are big reasons. And like I said, TCAs are very effective meds. They're not at all inferior to SSRIs or some of these newer meds. If at all, they're as effective, but it's only this side effect profile that makes it less favorable. And when there's this risk of suicidal overdose, TCAs kind of are a dangerous prospect, because we know that there's a very narrow margin of safety and overdose can be quite lethal.
Even I think in those somatic symptoms, these bodily symptoms, I have an experience. We have an experience here that they respond better to a TCS, if not equal. So that could be one reason. Another reason could be that the affordability aspect. In our part, it's like a 10 milligram of amitriptyline costs around 1 rupee or less than that.
Right.
While vortioxetine, the newer molecule, will cost 750 rupees for 10 tablets. So when you compare the cost, the difference is very huge. Probably that's one reason TCS are still in use. Are you able to see the questions raised?
I can. So there's this question about why twins have a greater chance of developing depression. That's only because, as I said, we know that genes are responsible for a big part of vulnerability to depression. Twins, we know what's distinctive about twins is that they share so much more of the genetic material, more so with monozygotic twins, and so there is a greater risk of depression. I'm afraid I do have to kind of wrap up soon enough because I'm headed to work. It's just the start of the day here. But are there maybe a last quick thing that I can answer before we wind up?
Maybe what's the role of quetiapine?
Okay, yeah. Quetiapine, that is a relevant question. I didn't go into that, but it was a part of that cluttered slide, crowded slide that had multiple mechanisms of action, included antipsychotic agents or D2 blockers. So quetiapine is being used quite prevalently for the treatment of depression, particularly when it's bipolar depression. In fact, FDA has approved it as a monotherapy for bipolar depression, and it's very popular because it has a lot of beneficial effects that extend beyond depression. It's a very effective anxiety remediating medication. It can help with sleep. And so there's a lesser odds of EPS that makes it favorable. But for standard major depression, you don't want to start there. It can be an augmenting agent that we could consider down the lane if some of the standard meds fail. But it's not a first line agent for just major depression. For bipolar depression, yeah, this could be considered.
I think since the time is running short, you want to go to work. We all would like to go to home. So,
all right. I think we'll call it wraps, and I think we can take down the questions and probably mail it to Arya for clarifications.
That sounds a good option.
That would be fine.
Absolutely, so, I'll be happy to do that.
Yeah, definitely. Let me quickly write down in a second so that before we close the session, so one is role of vitamin D, and then suicidal risk with antidepressants, and how long can you take antidepressants? I mean, I think that was already answered, up to 2 years, and depends on whether acute or continuation or maintenance. And yeah, so thank you so much, Arya. That was a brilliant presentation. Good to see you after a long time. And it's World Mental Health Day, and it was so germane that you came in and gave this amazing presentation to us. It's always a pleasure to have good people coming and presenting to us. And thank you so much.
Yeah, thank you so much for the opportunity and for attentive listening. I know it was long, it was a lot of talking, it was rather crowded and dense, so I hope it was worth your time.
It was really good, Arya. We really value your commitment to coming in and presenting this wonderful topic to us. And yeah, thank you so much. And I would also
great seeing you too. Bye.
Yeah, and I would also take this great opportunity to thank the moderator, Dr. Sijo. Thank you so much, Dr. Sijo, for sparing your time and coming in with good moderating. And all the delegates, faculty, friends, students, everybody who's here. I think you had a fruitful session. So until we meet with another highly impactful session that is coming on Tuesday at 7 p.m., we have a cardiology international webinar with a speaker from Australia and 3 speakers from Pondicherry and Tamil Nadu. I think that will be a wonderful webinar. It's on heart failure. I hope you will have a good session on Tuesday. So until then, so let me say goodbye from Believers Church Medical College and Hospital.